Good afternoon, everyone. So I thought I'll just kick off, seeing as there's no one introducing. So good afternoon to you all. Thank you so much for coming this afternoon. My name's Rachel Turner, and I'm an RAC GP academic GP Registrar at the University of Newcastle. And today I'm presenting sort of a part of my work, which is in investigating long-acting reversible contraception, and specifically looking at the association between rurality on prescribing of LARC by GP Registrars. And so I'd like to start just by acknowledging the rest of my team who can't be up here in Darwin with us today. So Amanda Tapley, Dr. Sally Sweeney, and Professor Parker McGinn, who heads the Research and Evaluation Unit at GP Synergy. So this research is funded by the RACGP with funding from the Australian government under the AGPT programme. So in terms of background, so around 2/3 of Australian women will use contraception at some point in their reproductive lifespan. However, around 50% of women will have an unplanned pregnancy, and 1 in 4 pregnancies are estimated to be terminated. And unintended pregnancies that don't result in termination are related to significant outcomes both for mum, for baby, and effects on the women's medical, psychological, economic and social outcomes. And that's not to mention the outcomes for women who do choose to have a termination. So long-acting reversible contraception, I presume, seeing as most of you have come to this talk, you may or may not be familiar with this. For those of you that aren't, LARC is defined as these 3 main methods. So we have the IED, which is implanted with progesterone, marketed as Mirena in Australia, or with copper, the medroxyprogesterone injection, and the contraceptive implant, which is marketed in Australia as Implanon. And these methods are the most effective form of contraception currently available. However, despite this, only a small proportion of women in Australia are using these methods. It's estimated about no more than 8.9% of women. And there are policies in place from the Family Planning Alliance of Australia, from the Royal Australian New Zealand College of Obs and Gynae to try and increase the use of these methods as they're the most effective. And this isn't unique to Australia. In the UK, the USA, there's policies in place to try and increase these methods. So today what I wanted to talk to you is some of the things that we've been finding in relation to the LARC and rurality. So there is limited but some research out there which is showing that the use of LARC is associated with where women live. So a lot of this work has been done by Jane Luck, based out of Melbourne. And this is reproduced from some work she did back in 2014, which shows the increasing prescribing of LARC as you move more rurally. And again, and I apologise for the blurriness of this one, but I just wanted to show you this nice data from the Hilda study in 2011, which again shows these differing prescribing practices of contraceptive methods depending on the location of the women. So in rural areas, we see a much greater uptake of partner sterilisation or tubal ligation, and also a higher use of the LARC method, so the IED, the implant and the injection, with women living more urban, using other methods such as the pill and condoms more frequently. So really, sort of, why does this matter? I guess by looking at this prescribing differences across Australia, we can better understand what some of the barriers are to increasing the LARC use by women, and by better addressing services and training in primary care and reproductive health to then address these needs. And it's been identified already that women in rural areas have a number of barriers that they already face in accessing contraception. So there's the cost, both in terms of the methods themselves, travelling distances to get to services. There's issues of access to specialised services such as family planning clinics or gynecologists. Issues with trying to find GPs who have specific training in relation to LARC insertion. And then also issues related to contraception, which may stop, for example, younger women from accessing services for fear if they're in a small community of being judged and so on. So the aim of my project was to determine what the prevalence and association of the rurality of practice was on GP registrars prescribing of LARC. And by looking at GP registrars and what they're doing, they are an important indicator of a future primary care provision and training for the primary care workforce. So the way that we did this was looking at the recent study data. Some of you may be familiar with this, some of you may have never heard of this, so I will go through what this study is. So recent stands for the Registrar Clinical Encounters in Training Study, and this is an ongoing large multi-centre prospective study that's been running since 2010. And registrars in 5 what were RTPs, so regional training providers through to 2015, and now regional training organisations from 2016 onwards, are asked at 3 points within their GP practice training to record 60 consecutive consultations. So they do this each in terms 1, 2 and 3 at about the midpoint of their terms. And we collect variables relating to the registrar themselves, the practice variables, consultation variables such as what are they seeing, what are they prescribing, what investigations are they arranging, what follow-up are they arranging, and then also educational variables, so what sources of help are they going to, are they generating learning goals, having difficulties, and so on. So using this data, we looked at the associations between LARC use and the practice location using multivariate logistic regressions. And the rurality was defined by the ASGS remoteness structure. And the outcome factor was the prescription of LARC, which was defined, as we mentioned earlier, as the IUD, both copper and hormone containing, the contraceptive implant, the injection, and compared to non-LARC methods, which were defined as progesterone-only pill, combined oral contraceptive pill, and the vaginal ring. And this was restricted just looking at data for women aged 12 to 55 and only when prescriptions that were issued for contraceptive-related problems. So we excluded any prescriptions of contraception where women, for example, were prescribed a Mirena for heavy menstrual bleeding or the pill for acne and so on. And we also performed a Pearson's chi-squared analysis of the specific LARC methods by rurality. So moving on to our results, so we had over 1,700 GP registrars contribute over 4,000 registrar rounds of data over the period from 2010 to 2017. And there were over 134,000 problems in the recent data for female patients of our target age range. And 4% of these women were prescribed a contraception, and 1% of these involved a prescription for a LARC method. So just looking at some of the demographics of our data, as you can see, the sort of gender term where a registrar has graduated is quite representative, which is the benefit of our large data set. Around 25.9% of the registrars were on rural training pathways. Majority are on the RAC GP fellowship programs. Around 1% are ACRM trainees and 1.4% working towards a dual fellowship. In terms of patient demographics, 7.6% of the patients were of a non-English speaking background and 1.8% were Aboriginal and Torres Strait Islanders, with a mean age of 34 and a CIFA decile of 5.7. And in terms of practice size, we had a good range of practices involved in the study, with around half and half large versus small practices, majority non-bulk billing, and 134, so 18.6% of the practices being in a regional, and 123, 17% of the practices being classified as outer regional, remote, or very remote. And so this is what we found. You can see are represented here in the green that the majority of prescriptions issued, as we suspected, were for non-LARC methods, so for the contraceptive pill or very small amount for the vaginal ring. But 25% of prescriptions were for LARC, and if you remember from our data from established GPs, this is actually significantly higher than has previously been estimated. There's also a limitation to this data. For those of you who are clinical, you'll probably recognise that the prescribing intervals for all of these methods are different. So for the implant, we'd be prescribing typically on a 3-yearly basis, for the injection 3 monthly, for the IUD likely every 5 years. Whereas the pill, we can presume that the script is often issued on a 6-monthly basis. And so it's likely that this is actually an underestimation of the proportion of women using LARC methods. Ooh. What we also saw on the multivariate analysis was that there is a significant association of the prescribing of LARC as opposed to non-LARC methods, depending on the rurality of the practice. So those GPs working in inner regional or outer regional remote, very remote practices were prescribing LARC more than non-LARC methods with an odds ratio of 1.47. And this just breaks that down a little bit further, just the dark green showing the non-LARC methods, light green being LARC, and seeing proportionately that increase in LARC prescribing as we become more rural. And what we also saw was this difference in the type of LARC method that was used depending on rural location. And Pearson chi-squared was significant for this difference. And what we can see in the outer region, remote and very remote practices, a large proportion were the injection. And again, similar to the first pie chart that I showed you, there's this limitation to this data in that we can make these comparisons sort of between the different ruralities in terms of these slight differences. But within the ruralities, we have to bear in mind that if we look, for example, here at outer regional, remote and very remote, that although 42% of prescriptions were injection, these are prescriptions that are issued on a 3-monthly basis. Whereas the implant and IUD have much greater prescribing gaps. So actually the majority of prescriptions are most likely for, the majority of not so much of prescriptions, but use is still for IUD and implant. So what can we conclude from this? I guess what this study shows is 3 main important things. That the prevalence of GP registrars prescribing of LARC is higher than has previously been recognised in established GPs. That GP registrars are more likely to prescribe LARC as opposed to non-LARC methods for women living in more rural regions. And that the type of LARC prescribed varies across different ruralities of Australia. And so what are the implications of this? Well, I think primarily the implications of this is it raises a whole world of new questions and new research possibilities to further understand why we see this difference and what we can do to better improve the reproductive health outcomes for rural women by knowing this. So, for example, do women who are more likely to have children live in rural regions? So are these women who have, say, had their children, settled down and want a long-acting method because they've now completed their families? Are there actual differences, different lifestyles in urban and rural regions which make different methods more acceptable for different women? Is access to contraception more difficult for women living in rural areas? Which I think for me, this is probably the key explanation of this data, is that women who may live further away from a medical facility are more likely to want a method where they don't have to keep returning to their doctor to collect a script. So they want something that's longer acting. It's also been postulated, are rural doctors more willing to learn procedural skills such as insertion of implant and IUD insertion, as rural doctors more likely to do other procedural skills? So is that just become part and parcel of their repertoire? And if that's the case, should LARC insertion training be more focused towards those registrars who are working rurally so that we can better serve these women? Another question is it just that there's a lack of specialist reproductive health services in these areas, which means that women living in major cities are attending their family planning clinics, their gynecologists, but those women living more rurally have to go to their GP out of necessity. And so does this increased demand for LARC in rural GPs reflect that we need better reproductive health services in rural regions and to take off this demand on GPs? So I'm more than happy to take questions, and I'm very keen to hear what your thoughts for reasons for this are, and things that we can do to better improve reproductive health for women living rurally. Thank you very much. Yes?
Surely being in contact with either a nurse or a doctor every 3 months, whereas a pill script is 12 months, 4 months and 2 repeats. Mm-hmm. So the pill script will actually go longer and with less medical contact.
It really depends, yeah. So that's what's quite interesting. And what we lack in the data, and what I guess I would love from this data, is to know we only see that snapshot of that GP registrar in that moment and what they prescribe. So what we don't see is that follow-up. We don't know how. All we know is that they prescribed that particular medication. Whether they issued a 1-month script, a 3-month script, a 12-month script, a 5-year supply, we don't know. And so that's a big limitation of the data. But you're right in that if we look at the fact that if women are being given a long prescription, so say a 12-month supply of the pill, for the reason that women don't want to come back, for me that says that that's an opportunity to be discussing with women the option of LARC, where they don't have to come back for 5 years, and introducing that at the beginning of the consultation when women attend for their repeat script. Yeah.
Is that me?
Yes.
Do you know, has there been any work done from a patient perspective about whether or not women do have a preference for long acting, or is...
There's a lot of work out there from a patient perspective, and a lot of my research has been coming from the doctor perspective, but yes, there's huge amounts of research, largely looking at what the main barriers are coming from patients, and what's been shown is a mixed bag of things. From a negative point of view, there is a lot of issues and hangover with women concerned about safety profiles, particularly of the IUD. There's that sort of word of mouth, and a lot of women have, say, parents, older sisters who had problems, and this sense of it not being the norm culturally, and it's that cultural shift that we need. What's really interesting, and one of the biggest studies was done, is the choice study, which I recommend you have a little look at, which was done in St. Louis in the USA, and this study is actually being replicated by Danielle Mazur and her team in Melbourne. They're due to be published soon, called the Accord study, and this works on a model of if you present LARC as a first line option in your contraceptive consultation, the majority of women, so in the study they did, 75% of women chose LARC when LARC was offered first line and the issue of cost was removed. So for me that says that sometimes doctors themselves value that women don't want these methods, because if we present it correctly, they do. But yeah, there's a lot out there.
Cool. Last question.
I was going to say, we're GP registrars in Victoria, MCCC, and as part of our women's health workshop, we all had training in implant-on insertion and all got a certificate in that. So I don't know if that's happening across Australia, but it's definitely being pushed in our education at the moment.
Yeah, and likewise with GP Synergy, I know that we received implant-on training, and what I would like to see in the future is that all GP registrars are trained in the insertion of IUD. I think it's as valuable a skill as a GP as everything else that we learn in venipuncture, everything. So yeah, I think hopefully this evidence can help support that need for that increased training.
So Rachel, can I just ask, are you from GP Synergy?
Yes, I'm a GP Synergy trainee.
So are you training GPs to become trainers of LARC insertions? That's what's deficient, I think, for registrars.
Yes, one day I hope to. I guess that is what I would love to do. My aim would be to use this evidence to support within all the RTOs formal training in IUD insertion, and that's something I would hope to work towards.
Supervisors can do that.
Not. They can. The only issue is that for valid indemnity insurance, you do have to have gone to a formal training course, and this is the thing. This is what's debated. Was you don't necessarily, but this is what people are told, and this is a big concern. I'm very happy to talk later because I'm probably running over time, but I've also done another study looking at the barriers that GP registrars feel that they face, and in the top 3 of barriers they face is a worry about their indemnity insurance, and so they're not learning this skill because they're worried about that, which is interesting.
And just to let you know, in Queensland we did some research of rural kids to see how they felt about using their GP for things like contraception and personal sexual health. And the rural kids said if they trusted their GP, they would go to their GP.
Yeah, that's it. I think the GPs are a great source for this. I think that it should be very much encouraged that the GPs be a point of call for reproductive healthcare, and doesn't necessarily need to be shipped out to specialist units. We're at a great place for that full holistic view of their reproductive and sexual health. Yeah. Thank you.